Welcome to our video on mucormycosis. Let's get started. We'll discuss the definition, risk factors, clinical features, as well as the diagnosis and management of mucormycosis. Let's start with definition. Mucormycosis is an invasive, life-threatening fungal infection, and the responsible pathogens are actually several species, most commonly Mucor and Rhizopus, and transmission is via inhalation of spores or direct inoculation, for example, during trauma. And on microscopy, you'll see broad non-septate hyphae branching at wide angles. And we'll show you what this looks like in a little bit. Now, the risk factors include poorly controlled diabetes mellitus, particularly ketoacidosis. Other risk factors include neutropenia, hematologic cancers, solid organ transplant, and extreme malnutrition. So basically, the idea here is that anybody that has a compromised immune system is vulnerable to this infection. In fact, Mucor and Rhizopus are ubiquitous in nature. Like, it's really easy to come in contact with these. And you're going to be fine as long as you have a strong immune system. So again, the people that you worry about are people who have immunocompromised states. Now, the most common manifestation of this disease is rhinocerebral mucormycosis. And the patient presents with fever, headache, nasal congestion, facial pain, and swelling. And that's not too concerning when you just see those symptoms alone. Might just seem like sinusitis or an upper URI with some nasal congestion. But it's actually catching these patients when it doesn't look super scary that can actually save them. And as it gets more advanced, patients can develop cranial nerve deficits like ophthalmoplegia or facial numbness. And once it's at this point, physical exam can show black necrotic eschars with purulent discharge in the nasal cavity or on the hard palate. And thankfully, you can actually identify these necrotic eschars fairly early on to tip you off that this is something serious. This isn't just a typical sinus infection. This is something very serious. This is rhinocerebral mucormycosis. And you can break this up by thinking of rhino and cerebral separately. Just imagine it starting in the rhino, so nasal congestion and those sinusitis symptoms. And then as it gets more progressed, it will just invade the brain. So you get the cerebral signs or the cranial nerve deficits. Now, clinical suspicion of mucormycosis should be followed by sinus endoscopy with obtaining specimens for microscopic examination and cultures. Also, a CT of paranasal sinuses can be performed. Now, that may reveal air fluid levels and bony destructions. And you manage it with liposomal amphotericin B, surgical debridement, and of course, treating the underlying cause. So when should you be suspicious of this? Well, think of any time a patient has symptoms of sinusitis and they're diabetic. That's the biggest take-home point. Always look in the nares and in the mouth and make sure you don't see any necrotic eschar. And if you do, get a culture, get a CT, and send them to surgery, basically. And of course, in addition to the surgical debridement, you're going to give some antimicrobials in the form of amphotericin B, specifically the liposomal form. Before moving any further, let's try a question. A 35-year-old male with type 1 diabetes mellitus and recent hospitalization for ketoacidosis presents to the office with fever, facial pain, and foul-smelling nasal discharge. And what's the best next step of management for this patient? So here we have a patient complaining of fever, facial pain, and nasal discharge. And alone, that's not super scary. But the remarkable history of type 1 diabetes and recent ketoacidosis makes us associate his current presentation with a possible mucormycosis. And again, this is a serious fungal infection that needs early diagnosis and early management. So the best next step in this condition is sinus endoscopy and obtaining biopsy for cultures. So let me show you what these look like. Here's a microscopic slide of a patient with mucormycosis. And note the broad septate hyphae branching at wide angles. And here you can see spotted areas of necrotic eschars on the skin overlying the orbit. So as this spreads, it just ravages the patient. Anywhere the hyphae have spread just causes necrosis because the hyphae invade the vasculature and the tissue gets ischemic. So none of it's viable. You just got to remove it. And you want to get rid of it and stop it from spreading. Let's end this lecture with a question. A 65-year-old woman comes to the physician due to worsening facial pain and headache that started 2 days ago. She was diagnosed with acute myelogenous leukemia, and she was started on chemotherapy 4 months ago. Her vital signs include a temperature of 40 degrees Celsius, a blood pressure of 140/80, a heart rate of 110, and a respiratory rate of 15. The physical exam reveals black discharge from the left nostril and bluish discolorization of the left eye. Her laboratory findings are significant for absolute neutrophil count of 300. Non-contrast head CT scan reveals a ring-enhancing circular lesion in the left frontal lobe. Which of the following is the best treatment option for this patient? A. Amphotericin B, B. Amphotericin B and surgical debridement, C. Clotrimazole, or D. Miconazole and surgical debridement. Okay, so this patient was started on chemotherapy for AML, and her absolute neutrophil count is 300, indicating chemotherapy-induced neutropenia. Additionally, she has facial pain, headache, black discharge from the left nostril, and bluish discolorization of the left eye. And the non-con CT shows a ring-enhancing circular lesion of the left frontal lobe, and that suggests an abscess. So all of these point towards the diagnosis of mucormycosis, and the best treatment option is broad-spectrum antifungal, like amphotericin B. That's the go-to antifungal for this disease, and then surgical debridement. Therefore, the correct answer is option B. Now, this slide reminds us of the diagnosis and management. So basically, you want to look inside the nares and the mouth, and you want to visualize it. And then you, of course, biopsy it, get imaging, and then start treating them. You got to be aggressive and quick with this. So amphotericin B and surgical debridement. So let's discuss why the other options are incorrect. Now, option A is incorrect because amphotericin B alone is not enough to treat mucormycosis. Surgical debridement is essential. You've got to cut it out. That tissue that died is dead. It's not viable. Now, options C and D are incorrect because clotrimazole and miconazole are topical antifungal agents that have not been proven to be effective against mucormycosis. Instead, systemic antifungal therapy with a strong gun like amphotericin B is needed. And that concludes our lecture on mucormycosis.